আগামী 4 থেকে 6 মে 2012 ঢাকায় অনুষ্ঠিত হতে যাচ্ছে যুক্তরাষ্ট্র সরকারের প্রধান উন্নয়ন সহযোগী সংস্থা একটি নাটিকা।
আসুন আসুন, কেমন আছেন আপনারা?
এই তো আপা, আপনি
ख़वातीन हज़रात, इन्फेक्शन कंट्रोल सोसाइटी आपको बच्चों की सेहत के बारे में मालूमात पहुंचा रही है, जिससे आगाही हासिल करके आप अपने बच्चों की सेहत को बेहतर रख सकते हैं। न्यूनेटल इन्फेक्शंस के बारे में हम बता रहे थे, जो न्यू बेबीज़ में या नए पैदा होने वाले बच्चों में पैदा होते हैं और उनको बीमार कर देते हैं। हम अलग अलग जरासीमों के बारे में आपको बताना चाहते हैं। इकोलाई का
About 10% of all births, whether you expect to have a problem or not, will result in some sort of a problem at birth. And NICUs are places that are, exclusively made for babies who are in those situations. We take care of babies who are premature, babies who have infections, babies who have breathing problems, many of which are not predictable at birth or prior to birth. Mom can do everything right and still find a problem at the end. So it's very good to come to a hospital that has a neonatal intensive care unit and all the things associated with it. It's a safety factor for the baby and the mother. First of all, there usually is a group of very dedicated neonatal nurses who have a special loving and caring ability for these children. We know everything about the families and the patients. In bigger NICUs, which we have the choice of working with, and I often go to Richmond and work up there, there's still specialized care. But here we get to know an awful lot more about each and every baby. I may have 3 or 4 patients, whereas in another neonatal intensive care unit I would have 15 or 20 patients. It's a lot more personal here, and you can spend an awful lot of time with the families and the kids. We try very hard to let the moms hold their babies as soon as they possibly can. And if they have to leave their baby here, we have something really neat. It's called a webcam. And we actually put a little camera on the baby, and the moms can log in on a secured network and see their baby 24/7 on camera. And they can share that with family members that they choose to share it with. So they can keep an eye on their child even when they're not here. And that seems to have helped an awful lot.
So he's having periods of apnea where he just stops breathing, and so the purpose of this video here is to capture what that looks like. So when you brought him back in, you just couldn't wake him up at all.
No, once we got him.
Once you
We started the apnea in the waiting room.
in the waiting room. Okay.
And when we got to the back and she put him on the pulse ox, he was at 80.
At 80. Oh wow.
And was back here.
Okay. Good thing you brought him back in. And there's little twin brother over there.
The respiratory therapist said put them on that machine would, once he stopped breathing, would kind of give him a push to start back.
Yeah, this is kind of like a CPAP machine, I think.
Yeah, before
a
he
nasal
got hooked
CPAP.
up.
Yeah, yeah. I would just capture just his lower face here so the audience can see what we got on his face here. So. There was another one. Capture that up there. Again, it doesn't retrograde cartilage. So in the waiting room, he was apparently pretty altered then. His oxygen level was in the 80s. Go again, breathing again now. Let me capture this one up here. It says oxygen levels aren't dropping, his heart rate's not dropping, but definitely pretty dramatic periodic breathing going on.
This is Bruce Jansen at the 36th Annual SDEF Hawaii Dermatology Seminar. I'm speaking with Dr. Albert Yan, Director of Pediatric Dermatology at Children's Hospital of Philadelphia. Dr. Yan, you emphasize very liberal testing for HSV, herpes simplex virus infection in sick neonates that present with any kind of skin interruption. Why is that?
Well, I think that there's good data to show that the diagnosis of neonatal HSV still tends to be delayed, and this has significant implications for morbidity and mortality in treating patients appropriately. One of the hallmarks of neonatal HSV in those patients who present with skin findings is interrupted skin integrity, which means vesicles or bully or skin erosions. And this can range from fairly subtle findings to a more disseminated, generalized phenomenon as seen in more disseminated disease. Early diagnosis is critical to being able to treat these patients properly and preventing some of the complications that can result, which includes residual neurologic deficits or even death when these cases are not treated promptly. So when I'm confronted by an infant or neonate who has interrupted skin integrity, I tend to think about neonatal HSV. It's really important to keep this disease in mind because it tends to be underdiagnosed and leads to a delay in eventual diagnosis if we don't maintain a high enough index of suspicion, which is why when I think about interrupted skin integrity in neonates, on my differential diagnosis is neonatal HSV first, followed by neonatal HSV second, third, fourth, and fifth, and then I start to consider other things on the differential as well.
And what's the best way to screen for the HSV infection?
Well, in neonates, you have to look at the various different places where you can find HSV and recover it. And if you have skin lesions, then the skin is a good place to start. If you don't have skin lesions, or as part of a more complete workup, you should also look at the conjunctiva, you should look at the oropharynx, you should look at the perianal area and the blood as well. The perianal or rectal swabs, though, can be confounded by the fact that it can reflect maternal colonization. So that's the one area where you may be best off delaying a screening study of that site for at least 24 to 72 hours after birth. Otherwise, screening multiple different sites increases your diagnostic yield and your ability to pick up the diagnosis and treat it properly. In